Perfect. So welcome everybody to Hot Topic. Hot Topic is a virtual small event that we're hosting at Amira on a monthly basis to bring experts to talk about all of menopause and the myth and everything that's still not talked about today. So what we have found is that there's a lot of lack of not only education, but like understanding. And so this is kind of like our hope to change that and move forward. So today we have Dr. Anat Sapan, and we're super excited. Before I pass it on to her to present, I want to give like a quick introduction on Amira and who we are. So Amira is came out of MIT, engineers. Lowen's on the call, is a founder. And we started with this mission to help women actually stay asleep through nighttime hot flashes. And the way that we do this, we actually taking a very unconventional approach where we're using biosensors to be able to predict hot flashes and automatically provide cooling to women. So I'm super excited. We are launching our first units in a month or so. So yeah, if you want to talk more about what we do and our mission, we'd love to. But otherwise, I pass it to Dr. Anat.
Hi, everyone. Thanks for joining. Menopause and perimenopause is not only a hot topic, but it's a topic that's often misunderstood. And so I'm honored to be here, and I'm excited about the product that Amira has for various reasons. Most of all, that it's an alternative for many women who are not able to use HRT, hormone replacement therapy, for hot flashes while they're sleeping. So that's definitely a niche area, and I'm excited. I saw them. I met Lowen. I never can pronounce her name right, but I met her at one of the talks that I gave. Hi, Lowen. And I was super excited because they're led by women, smart women who are so far from perimenopause that she had very good questions. And so here we are. So today I want to talk about perimenopause and menopause. What is it? What's the big deal? Why we should be worried about it? What the long-term benefits of doing nothing, and what are the benefits of doing something, and why it's important for us to be very proactive in treating symptoms that we develop. And so I'm going to share my screen. Is my screen up?
Yes, your screen is up and running.
Okay, so here we go. Oh, why can I not change? Okay, there we go. So basically, perimenopause and menopause. So menopause is defined as 12 months without a period. And so at some point in our adolescent years, our brain connects with our ovaries and sends signals for the ovaries to start making estrogen, progesterone, and testosterone. These are the sex hormones. And these sex hormones will start to like raise. And as you see here in puberty, these will increase and they'll get to a pretty level steady state, even though during the month they do change, and that's what causes our period. But essentially, the overall levels are pretty steady, and that's the fertile years. And at some point in your late 30s, early 40s, the ovary is like, hey, I'm about to retire. I'm not going to show up all the time. And the first thing that happens is that the level of progesterone starts to decline because the ovary is just not doing what it needs to be doing. And as this declines, we start to have symptoms. And so I call perimenopause as puberty in reverse, because in puberty, we see a lot of behavioral changes, emotional changes that occur as these hormones start to like elevate and reach their peaks. In perimenopause, we start to have symptoms that appear out of nowhere. So oftentimes, one of the first symptoms when the progesterone starts to decline is women's periods will start to become longer or shorter, or they'll have infertility. And that's often due to the fact that the progesterone is dropping. In our bodies, we have 100 times more progesterone than we do estrogen. So when this starts to decline, we feel it. And the other symptoms that often accompany that is sleep issues. Many women in their early 40s will stop being able to sleep as well as they've been sleeping all along. And that's primarily because of the progesterone decline. And when they go to see their doctors, the doctors will give them Ambien or some other sleeping aid to cover that symptom. As the years go by, the estrogen is also going to start to be erratic. It's going to 1 month work, 1 month not, 1 day work, 1 month not. And the symptoms that usually accompany that are changes in mood, depression, anxiety can show up. Women will show up to their doctor saying, wow, I have this newfound depression. I'm not excited about things. I can't be motivated. And they'll be oftentimes be given medicines like SSRIs, like Lexapro or Prozac or any of those. And what that's doing is masking the symptoms. Now, a lot of the symptoms of perimenopause can be related to other conditions as well. But if you look at the root cause, if the root cause is actually the decline of these hormones, then by replacing these hormones, we can correct those symptoms, as opposed to just putting patches on them. And so the other hormone that is always a shocker to people is a testosterone. We have testosterone. That's right, ladies. You have testosterone in your body, and we have more testosterone than we even have estrogen. And as the years go by, these levels start to decline. And with that, we see the inability to make muscle mass the same way. Our libido drops. So there's a whole list of symptoms that occur during perimenopause that I want you guys to be aware of. And these have to do with the decline in hormones. So some of these could be hot flashes, because the thermoregulation. But I'm going to just go quickly here. So this is where it comes, the connection. This is what your normal cycle looks like. The red is estrogen, and the blue is the progesterone. And what I want you to see is that the chart on top is usually what you see in the textbooks. But in reality, look at how much more progesterone we have. And so progesterone is super important, especially in the perimenopausal years. This chart is important to see that all these hormones basically show up from cholesterol, and cholesterol is an ingredient that makes all these hormones. And so I often refer to the ovary as a bakery. And imagine if you wanted bread and you kept delivering flour to the bakery, but the baker is like, hey, I'm closed on Monday and I'm maybe working on Tuesday and maybe this weekend I'm going to take off. That's what the ovary is doing in perimenopause. As it decides to work on it, you're going to have a whole bunch of flour in the parking lot. And that flour, substitute the word cholesterol, is why we often see cholesterol increasing in women in perimenopause. So I hope I didn't confuse all of you with my analogy, but this was a huge aha moment for me, because I forgot, even being in medical school, this big complicated chart. And at the end of the day, at the top of the chart is cholesterol, and cholesterol goes on to become progesterone, testosterone, estrogens. It also becomes cortisol, which is our stress hormone. Okay, so all of these start with cholesterol. And so it's not shocking to see that so many women, and even men, because they make these hormones, end up having an increased cholesterol. And so the root cause is these ovary in our case, and the testes in men's case starts to slow down, and we see this rise. Super important. Okay. So this chart, I want to talk about how important estrogen, progesterone, and testosterone is to every organ in our body. The OBGYNs primarily relate the decline of estrogen with hot flashes and vaginal dryness. And so you'll often see doctors have a very limited scope of knowledge and saying okay, if you don't have hot flashes or vaginal dryness, we're not going to address with hormones. We're going to give you other meds. But the reality is that every single organ is affected by this. So here we have vaginal dryness, the irregular periods that we might have. Can you see my cursor? Yeah. So that's this slide here. The brain, estrogen, progesterone, testosterone are some of the strongest chemicals that affect our brain's function. So they affect the way our brain utilizes serotonin, which when that declines, we see depression. Dopamine, which is our reward centers. GABA and glutamate, that is what is used to help us sleep. So it makes sense that the decline of these hormones will give us symptoms such as anxiety, sleep disturbances. Also, the brain regulates our temperature. So it's no wonder that when the estrogen declines, we have hot flashes. Okay, mood changes right here. The other thing is estrogen is super important in how our cardiovascular system works. So as we lose estrogen, our blood vessels become stiffer and we're at a higher risk of developing plaque. Because remember that cholesterol, it's running around in your blood and it's very sticky. And as these vessels become harder, you form plaque, which makes sense why menopausal women, the number one killer in menopausal women is in fact heart disease. Okay, heart disease, number one killer in women. Bone loss, we can have osteoporotic changes. So estrogen and progesterone are needed for that. This is a picture of nerves. Nerve conduction is really important and uses progesterone and estrogen. And one of the things we see is more women in the perimenopausal state will develop MS. Muscular sclerosis, that's a disease where you have demyelination of the nerves, and that there's a role that progesterone plays in that. This is sleep, progesterone, we talked about that. These are nerves again, and conduction. For example, conduction of your heart, conductivity has to do with estrogen, which is no surprise that we see a lot of women suddenly have palpitations in their 40s or 50s. Okay, and yes, palpitation and some of these other symptoms can run with other conditions like thyroid disease, but oftentimes it is estrogen that also. Muscle, this is here for muscle because testosterone helps with that. This here is a bladder. Many women will have increase of urinary incontinence or incontinence when they're leaking urine or hyperactive bladders because the estrogen plays a role in the bladder and in how elastic the bladder is and how that is. This is a picture of the bowel. And oftentimes what happens is with the decline of these hormones, especially estrogen, we have immune deficiency. So we start to see more autoimmune diseases or SIBO in women in their 40s again. And these are things that affect the GI and joint pains, especially frozen shoulder, joint disease. There's a heart again, there's a brain. So when you lose estrogen, one of the biggest things that happens is brain fog and dementia later on. And this is the liver. The liver without estrogen starts to have more difficulty in clearing. We start to become more sluggish. Sometimes insulin resistance occurs. And this is for the skin. There are skin changes that occur. So overall, I want you guys to see that hormones affect every single aspect of our body. And that many of the symptoms that we have in perimenopause and in menopause could be mistaken or just treated with other Band-Aids to clear up those symptoms. I'd like to ask if anyone has any questions at this point. Do we have any questions that are blaring before I continue?
There's one question that came
Okay.
up. It was more about Amira and IUD.
I'll get back to that later, but
Okay.
let me put it out there. Does anyone have any questions that are burning, or am I speaking too fast? No. Okay, then I'll continue. So as you can see, there are many signals in hormone therapy and they affect every organ in our body. And it can get very, very complicated because many practitioners are not even speaking about this. There was a survey that was done that said that only 7% of doctors feel comfortable in talking about menopause. And when they surveyed OBGYNs that take care of 100% of their patients are women, only 30% felt comfortable in discussing menopause. So if doctors are not comfortable talking about it, how are we expecting patients to be comfortable, and where do we get answers? So to understand why there's such a deficit in physicians being aware and able to speak about this, we have to understand what happened. So I'm going to give you guys a little bit of a history lesson really briefly. So hormones have been around since we've been around, okay? And 100 years ago, we used to live to only be about 50. So menopause wasn't the biggest deal, right? But today, the average age of menopause is 51. And the average age, life expectancy is about 83. By the time we live to be 83, that life expectancy is going to be probably in the triple digits. So we're going to be living 40-50% of our lifespan in this area, and we need to know about it, and our doctors need to know about it. So what happened? In the 1940s, these hormones were isolated, okay? And they were isolated and they were put into pharmaceuticals. Synthetic versions of estrogen and progesterone were made into drugs. And they were used to treat up to 40% of women in the 70s, 80s, 90s were treated for menopausal symptoms. And the cardiovascular benefits were actually noted. The benefits for brain, for GI were noted, besides just the benefits of hot flash reduction and sleep, right? So these were around. But there was a study that came out, and that study was called the Women's Health Initiative. That was started in the early 1990s, and in the year 2002, erroneously, the insignificant increased risk of breast cancer, which was 1 in 1,000 in the progestin, the synthetic progesterone arm, was released. And it was said that, oh my God, you're going to get breast cancer if you're on hormone replacement. And millions of women stopped taking their hormones. The alternative community continued to treat women with bioidentical hormones during that time. I call that time the hormone prohibition, but women were still treated with it, okay? And now, 22 years later, we basically look at that study and say, you know what? It was a bad study for many, many reasons, and I could talk about that ad nauseum, but it was a bad study. So basically now there are availability of non-synthetic hormones, and those are called bioidentical or body similar, or there's a whole bunch, they call them bioidentical, body similar, there's a whole bunch of words, but anyway, those are pretty much hormones that look like what your body is making, and there's different ways to take those. So there's synthetics, which was Premarin. Premarin was the conjugated estrogen that was used in the WHI study. Synthetic hormones are still in all of your birth control pills. There's not one birth control pill or IUD that I can think of that does not have synthetic hormones in it. And hopefully in the future that will change. But as of now, the only hormone replacement that is being used, for the most part, I can't imagine someone using synthetics, is bioidentical. And so that's that. Any questions? Does anyone have any questions? No? Any questions popping up there, Maya?
Not that I see.
Okay, I'll just keep going. So why is it important to replace? And the way I see it is not only for symptom alleviation, okay? But when I look at hormone replacement and women's health overall, to me, hormone replacement is a pillar by which longevity for women stands on. Because once we can correct sleep, we can correct the way your gut is functioning, we can help you with stress management. These all relate to the hormone replacement and to how you control your symptoms, okay? So, and now I'm going to talk about some myths. It's really hard to talk to people without just give a lecture without having questions. So I hope I'm doing okay and not boring you all. But I think these are really important points that I want to touch on. So there's a lot of myths out there, and there's a lot of misinformation that comes out. And I made a bunch of myths, and I hope that I can educate you on this. So number one is hormone therapy increases the risk of breast cancer. Well, that's a myth. That was a myth that was perpetuated by the WHI study. And that study basically said that there was an increased risk of breast cancer. We now know that that minor increased risk is 1 in 1,000, and they're attributing that to the progestin, the synthetic progesterone. And what we know is that women who were treated with hormone replacement, who then develop breast cancer, have a better prognosis. Their cancer is less aggressive. I am not in the belief that hormones that are identical to what your body makes cause breast cancer. Otherwise, in our 20s and 30s, where remember back in the fertility phase where our hormones are the highest, we would see a whole bunch of people with that. So breast cancer has different things that can cause it. It could be genetic, and that's only a small amount of breast cancer is genetic, 5 to 10%. So the risk for women of getting breast cancer is about 30 in 10,000 have a risk, and we're all at risk for all sorts of cancers. Cancers could be genetic, they could be from environmental causes, from chemicals that we're exposed to or that we're eating, from stress, from our body's inability to monitor what is going on in our body. So there's many factors that play a role in what causes a cancer cell. Is one cell that decides to turn on and continues to replicate and can break off and lodge itself somewhere else. And so if we're not sleeping, our body can't patrol that area. If we're exposed to toxins that are causing it, or we're exposed to chemicals that are causing it, that also can cause that cancer. So I am not in a belief that something that your body is naturally making, these hormones, is causing the cancer. There will be breast cancer cells that have a receptor for estrogen, progesterone, HER2, or any other number of receptors. Receptors is something that was identified in the 1990s. Every cell in our body has receptors, and receptors are like a lock and key. And the hormone will come and nestle itself into the receptor and then cause an effect of something to happen in that cell. All cells in the body pretty much have receptors for estrogen, progesterone, and testosterone. That's why the deficit of these, the decline of these hormones, causes all the changes that I talked about before. Now, breast cells have estrogen and progesterone receptors on them. And so if a breast cell turns itself on, it is not unusual that those receptors will be there. As the cell continues to divide, there will be cells that will no longer resemble the original breast cell. And those cells might not have those receptors on them. But a breast cancer cell will usually have some sort of a receptor on it. That does not mean that that causes that cell to turn on. So I think there's a lot of confusion out there about estrogen receptor statuses and how the cause and effect of hormones on the cells. I think that's what leads us to think that for many doctors to say, oh, if you have an estrogen receptor positive, you cannot use estrogen. In the 1960s and earlier, estrogen was in fact used as at high doses to treat women with certain breast cancers. And keep in mind that medicine is constantly evolving, and every decade we learn more and more and more. And what we knew in the turn of the last century, today, much of that is thought of differently because we've learned to explore that more and more. And so things are constantly evolving. There's a great book out there called Estrogen Matters, where Dr. Avram Bluming, who's a medical oncologist, went and looked at the breast cancer debate about hormones, and showed that women who were treated with hormones had a lower recurrence rate of breast cancer when they were treated with hormones, and they were treated appropriately for their cancer and then treated with hormones, had a lower risk of recurrence. Women who were treated with hormone replacement and then developed breast cancer had a less aggressive cancer. So it's an interesting topic, and I encourage you all to read this book. I think it's a great book, and it really talks about this. Now, many oncologists are not up to date about this stuff, and I think they need to be, because that's a topic that they need to talk about. Okay, number 2, natural menopause doesn't require.
Doctor, there's like 2 questions that came.
Oh, good. Okay, good.
And
Let's go back. Go
because
ahead.
it's on the same topic, I just wanted to make sure that we
Okay, go ahead.
So we got one from Tanya. What was the statistic on getting breast cancer for all women?
So that's about 30 in 10,000 women. And that's why when women, and that's a good point that it's, when you look at it, 30 in 10,000. So then if you say, okay, if a woman says to me, well, I have a family history of breast cancer, that family history only plays a 5 to 10% increased risk. So now her risk would become, instead of 30 in 10,000, let's say it becomes 40 in 10,000. That risk is so small, right? And so it's basically the same risk as for the general population. But without being treated with hormones, the risk of heart disease is still the number 1 cause of cancer. The heart disease is still number 1 cause of death in women in menopause. Osteoporosis, which leads to bone fractures, is still very high. A woman could lose 50% of her bone mass in the first 5 years that she's in menopause. Dementia, there's an increased risk in women who are not treated. So when you look overall, every patient needs to make a decision that's good for them, but they need to, I believe that all patients need to be informed and to be able to make the best decisions that work for them. Just like we decide whether we're gonna drive our car through a bad neighborhood in the middle of the night or park our car in downtown San Francisco in the evenings. We have to make a decision, like, does this work for me or not? What is the risk? What am I doing? Same thing goes with hormone replacement. Same thing goes with any sort of medical decisions that you make. As a patient, you need to be informed. You need to understand what the risks are, what the benefits are. And the benefits, in my opinion, of hormone replacement, when it comes to vein health, bone health, heart health, and other health, which we discussed the deficits on, is really important. So I hope that answered that question.
There's another question
Okay.
from Tori. Why do they typically prescribe birth control for perimenopause instead of HRT? She's trying to figure out the pros and the cons.
So that's a good question. I think that the knowledge is really lacking in conventional medicine. And I say that having been on 32 years worth of birth control, that's what we had for years, and that's what we treated with. And so the tide is turning, and I hope that conventional medicine and big pharma will wake up and see that if we're saying it's not safe for women to take who are in perimenopause, why would it be okay to put women for 30 plus years of their lifespan on birth controls with synthetic hormones? And that's what's available now. Now, do I think that birth control doesn't have a place? I think that giving a woman a right to her own fertility is super important, and we can't, undermine that, especially in a climate like we have right now in the U.S. We need to have the rights to our own fertility, and sadly, there are limitations right now. Like, one of the best options for many women is an IUD with copper. IUD does not have hormones in it. The IUDs with progestins in it, that's synthetic progesterone, have some that act locally. Some of it will become systemic, but birth control is all synthetic hormones, and those carry the same risks that we see with the risks that we saw with hormone replacement that was synthetic.
Awesome, thank you.
That the last one. So okay, so I'm gonna move next. So next is next myth that I want to talk about was natural menopause doesn't require hormones. So lots of women our moms' ages who went into menopause during the menopause prohibition were not even offered hormone replacement therapy, and those women suffered as a result. As a result, today we see dementia rates that are higher. We see osteoporosis rates that are higher. We see more women being hospitalized in the later in life into the ICU with urosepsis, which is infection of their urinary tract, we see more women die of heart disease, which again is the number one killer in women. So those women were not afforded the options because all of a sudden that was taken off the table unless they saw care from alternative medicine doctors who continued during this whole time to use bioidentical hormones and treat women. And so do they require it? I think we see from this conversation that we've been having today the benefits of hormone replacement in the long run. And so I don't think that it doesn't require it. Again, it's a personal choice that you make for yourself. Number 3, always use the lowest possible dose of hormone. I don't agree with that because there's a level of hormone that you need not only for symptom relief, but also to be able to protect your bones, your heart, and your brain. And for women in menopause, what I do in my clinic is I do a 24-hour urine collection to look to see where those levels are that in fact they're protected. During the time that a woman is in perimenopause, I don't check those levels because her ovary is making hormones that will vary on an hour-to-hour basis, on a day-to-day basis. And so that will only give me a glimpse of time. So I see it as a waste of a test. And also that's why I don't think that any testing for hormone levels in a perimenopausal woman is important. Her symptoms will be the perfect test to tell her where her hormone levels are. Okay. Myth number four, only 1 or 2 hormones are safe. Okay, that's not true. Most doctors are comfortable talking, maybe if they are comfortable talking about estrogen and progesterone, but testosterone is another hormone and DHEA is another hormone, and testosterone is very safe in women. We have more testosterone in our youthful body than we do estrogen, and that plays a role. And so I believe it's important to replenish that as well, and to effectively balance the hormones. Okay, number 5. Are there any questions that have come up since? No? Keep going.
There is no, there's none.
Okay. So all hormones are created equal. So I don't believe that all hormones are created equal. We already spoke about the synthetics versus the bioidentical or body identical. There are different ways that you can take hormones. There's when you ingest a pill, it goes into your GI tract and gets absorbed and then needs to be processed by your liver and then makes it into circulation. When you take hormones through the skin, whether it's through an oil that I use in my office or through creams or patches, that goes through the skin into your bloodstream. So that avoids what we call the first pass. That's when it goes to the liver. Injections bypass that also. There are every formulation will have a different ingredients in it. Some of them will have different solvents or ingredients in order to be able to carry that hormone through your skin. So in the case of patches or creams will have different, or in my case, I use organic oil as a carrier for the hormones, but there's different chemicals that are made that are added to it. And so I think that it's important for women to understand they might be allergic to something. They might not want to have additional chemicals into their system. So that's where that comes into. And I guess I skipped number 6. I don't remember what number 6 was, but the myth number 7, after 10 years of HRT, you need to stop. And I think that's a myth because why would you want to then go into the symptoms of menopause and then not afford yourself the protection that you'd be otherwise affording yourself? And so another example of how the medical community is slowly catching up, the American College of OBGYNs used to say, okay, take it until age 60. Now they said 65, where many doctors are now who do menopause health. So not many doctors, but only the 30% of us that feel comfortable are now saying, hey, why stop at 65? Let's continue pushing it until later on. So that's that. I think that's the end of that. So now let's take it to whatever questions you have there.
Yeah. So we have
Okay.
first question from Beth. As someone who had terrible reactions to progesterone birth control shots, so severe mood issues, weight gain, are there any risks for her to consider hormonal therapy in perimenopause?
So sadly, you're the exact reason why I bring up the difference between synthetics and bioidenticals. Many women have reactions to the synthetic progesterone, and that does not mean that you'll have a reaction to bioidentical progesterone. Your body naturally lived, depending on where you are, had a huge amount of progesterone. And so it's not unusual for women to have reactions to the birth control, the injection. Some women even have a reaction to the IUD because of the synthetic progestins. I want to comment that when I was in medical school and residency, we often used the word progesterone interchangeably to mean progesterone that's synthetic, like the progestin or the bioidentical. At that time, the only thing that was available was the synthetics, and that for the medical community through big pharma. They were available through compounding pharmacies, but in medical school and in residency, you don't really interact with compounding pharmacies as much. And so it was big pharma that basically taught us to use these interchangeably. And so it took a while to be able to, it's like saying like all cars should, or automotive, or all cars can include motorcycles and trucks, right? We know that that's not true, but we can call them cars, right? Because they have wheels on them. So it's the same reason why your doctor often would confuse, or not confuse, but interchangeably use the word progesterone with progestin, where in fact they're not the same. And we need to like really divide that out. So back to your question about having a reaction to the synthetic progesterone and fearing taking bioidentical progesterone, and you should not. One of the things is that right now the only commercially available progesterones is one of the only ones is prometrium, which is a progesterone made in peanut oil. So some people are allergic to peanuts and can't take that. And so they would want to have other sources. So that's where the ingredients that are in your medicine, you want to know what's in it, because there's a whole bunch. And I hope that answered your question. But do not fear going on progesterone because of that. Progesterone is super important, even to help treat women who have endometriosis, or help women in the early part. There's early perimenopause, which oftentimes that drop will cause sleep changes in women and anxiety. Those women do really well with supplementing progesterone. Progesterone is a very high state in pregnancy. We have a very high level of progesterone, and that's why some women after pregnancy, that deep cliff dive of losing that progesterone can cause postpartum depression. And I've seen patients treated for postpartum depression with progesterone. So, and without needing to go on SSRIs. So that's something to keep in mind. So don't give up on it. Definitely seek it.
Thank you. Another question. So for those of us who have been on an OCP, now have an increased risk of breast cancer, ? Are these risks cumulative?
So those risks occur, is it cumulative over the years? Like I said, breast cancer has multiple factors that we have to look into. And so there's not, I can't say if they're cumulative. I would think that they would be cumulative. I say that having, like I said, I was on 32 years of birth control, so I'm not thrilled about that risk, but it could be, it's important to do your breast exams annually. It's important to get mammograms when you need mammograms, to pay attention to it, to really, we're all at risk. We have breasts and we're at risk for breast cancer. And so what you can do to be on surveillance and screen and reduce your intake of anything that can increase that. So that's where seeking alternatives to birth control that use synthetics is important. But you have to weigh it. I mean, what's the risk of getting pregnant versus not using it, right? So every single person has a different bunch of parameters surrounding their decisions, and that's where individualized informed consent is super important. What is your alternative approach to protecting yourself from getting pregnant or from having heavy cycles? So I hope that answered that question.
We have a lot of questions. Hopefully we'll be able to cover them.
Okay. I'll do rapid fire then. I want to answer.
So do your patients on testosterone have any issues with hormonal acne?
So in my clinic, I start low and find the range that people feel good in. So if someone's having symptoms, they are below this level. So let's say this is the window of where I want to go. So if their levels are too low, they're going to have symptoms of whether they're having symptoms of low libido or decreased muscle mass, right? So the idea is to find this happy spot. When you overshoot, you can have symptoms of excess. And acne is a symptom of excess. And that just means that the dose that you're on is too high. And so the idea is to like start low and find that happy medium, as opposed to like with pellets or injections, you're taking a stab in the dark and you're like, oh, is this dose going to be too high? Am I going to shoot right in the middle? Is it going to be too low? So I take the approach with all hormones of starting low and finding that happy spot where your symptoms are relieved, but you don't have symptoms of excess.
Awesome. I was on birth control for 30 years and loved it. Went off at 50 years old. Have I done harm with body having been on it this long?
So like I said, I was on it for 32 years. You know, being on birth control has its risks. I sadly learned about the risk of osteopenia, which is your loss of bone density. And that's because when we're on birth control for a long time, our body can make something called sex hormone binding globulin that basically sees all this foreign hormone and like eats it up like a Pac-Man and holds on to it. It reduces what's available, and so you're at an increased risk of bone thinning as well. And so there's a lot that we're learning all the time, but if you were to continue with something, I would encourage you to look for bioidenticals. I would encourage you to get a DEXA scan and learn where your bone health is now, so that you can do what you need to do to increase that bone mass. And one of those, the pillars of that is hormone replacement, as well as weightlifting. You need both estrogen and progesterone for bone remodeling. And so that's super important, in addition to a healthy diet that has calcium in it.
The other question is, should all 4 hormones be replaced? It seems like most people just get prescribed estrogen and progesterone and then have to push hard for testosterone separately afterwards. Haven't heard of DHEA replacement.
So most doctors only are aware of estrogen and progesterone for right now. Testosterone is needed, and my patients do great on it. And DHEA is also something that on that complicated pathway that I showed earlier is on there, and it helps with symptom relief. What happens is right now there is no pharmaceutical testosterone available for women. There's over 10 of them for men. They're none available. And so doctors just don't have anything to prescribe that big pharma makes or that your insurance will cover. And so we get those from compounding pharmacies. Those are pharmacies that are able to make medicines that big pharma does not have available, or make medicines that are available, make them available through other modalities or have other ingredients in them. Do I think that it's important? In my practice, I replace those in women that need them. Now, sometimes there are women that don't need testosterone because testosterone sometimes drops later on in life. And so maybe once she's in menopause. Sometimes it's earlier. It's important to understand that a lot of chemicals that we're exposed to every day, like plastics or pesticides, are what we call endocrine disruptors. And so those are chemicals that can bind to those receptor sites that we naturally have on every cell in our body, and they can bind. So they might look like estrogen and bind there, or they might look like testosterone and bind there, or they might cause our body to get rid of testosterone earlier on, or estrogen. So we're seeing women go into perimenopausal symptoms at an earlier age, and how much of that has to do with what we're exposed to environmentally, and so it really depends on what symptoms we're treating. And yeah, in my practice, I look at all four of those.
Thank you.
Okay.
Do you recommend bioidentical hormones to a postmenopausal woman with a stroke history?
So every decision, every patient needs to, it's an individualized decision. And so it depends what was the cause of the stroke. When we speak about stroke, it's important to understand that one of the biggest risks of birth control pills is what? It's blood clots. And a stroke, it depends if it's a bleeding stroke, if it's a blood clot stroke, right? So it really is individualized. But birth control, the number one risk is DVTs. That's a big risk that we see. That's because of the conjugated estrogen, the synthetic estrogen. When we use bioidentical estrogen, and it's transdermal, that risk of blood clots is very minimal, where we can't even use it on women that have clotting disorders, certain clotting disorders. So it really depends on the individual patient and what their risks is, what their age is. But I wouldn't say that it's an absolute no.
I have heard that bioidentical are not FDA approved. Can you just speak to that?
So lots of things are FDA approved that have risks on them, right? Like OxyContin, look at like any medicine has its risks. FDA approval is something that is FDA approval. It's not that compounding pharmacies are not FDA approved. Their ingredients are FDA approved, and those pharmacies go through rigorous regulations and have procedures, but they're not big pharma. And so that's something that's used. There's a war sort of between big pharma and compounding pharmacies because of market share. And so I think that's beyond the scope of going on here, but they are regulated. They are highly regulated. And so I believe that they're safe. It depends who's making them and what they are, and I don't know if I answered that question, but it's a complicated question.
Yeah. And then we have, how does diet and drinking alcohol affect our hormones later in life?
So one of the things that many women will see when you get older and you drink, it disrupts your sleep. And so remember that chart that I had, the liver there. Hormone reduction affects the way your liver processes. And so liver is very complicated. And so one of the analogies I like to use is, think of the liver as a washing machine, okay, as a laundromat, right? You go to the public laundromats and they have a bunch of machines. The more stuff you bring to it, the more you're going to backlog those machines. If you take chemicals, or if you're having alcohol, or if you're not, the laundromat is not all their machines are working properly, you're going to have a backlog. And so that's what happens when we're exposed to a lot of pesticides, when we're using all sorts of chemicals that leach through our skin into our bodies. That's what happens with the decline of hormones. Our liver is not processing efficiently. And so as a result, you see that many women, when they drink, will not be able to process the same way they did before, and that affects their sleep, and that affects the way you feel. I hope that answered that.
Yeah, I think
yeah.
as a follow-up question to that, how does it affect it when we are like consuming alcohol, like let's say today, let's say like I'm not experiencing menopause, but I'm consuming alcohol. I'm not, but let's say I am, and then how
Well,
does
let's say you were. Cheers.
how would that like affect my health when I get to that like age?
So it really depends, like on how much you're drinking, right? If you're having like a glass of wine or two and you're fine with dinner, as opposed to like a bottle or two or three cases a day, right? It's going to affect your liver's ability to function. So everything is within moderation. An alcoholic liver is a liver that's not functioning ideally because those cells are either ill or a lot of the liver is very complicated, but a lot of the pathways are not able to be working. So that's a laundromat that has a lot of out of order machinery there. It's not going to be an ideal place for you to go. You're going to have a big backlog.
Right. So we can say that it's like cumulative.
Cumulative. Well, it depends on how much you're drinking, right?
Yeah.
If you're, yeah.
Okay. I discussed this because I know it's a myth. I have autoimmune disease, specifically ulcerative colitis and alopecia. I don't know if I pronounced this right.
Yeah.
How does HRT affect patients like me?
So again, it depends. Alopecia is, for people who don't know, is hair loss. And so hormones can affect hair loss, chemicals can affect hair loss. Some of it could be genetic. There's different factors that can affect hair loss. Ulcerative colitis is an autoimmune disease that affects the gut. It's one of the many gut autoimmune diseases. As your hormones decline, many times there will be an increased flare of autoimmune diseases. And that's because our immune system is not able to function at its ideal levels. For example, you need to be able to sleep. So I'm just going to make this really simple. If you need to sleep, during your sleep is when your body gets rid of toxins, it's when it's patrolling, it's when things are working out, right? If you're not able to sleep, your body's not able to do these things. And that's how this can affect it. It affects your stress levels, can affect your sleep, can affect the way your autoimmune disease flares up. Or sometimes women will just show up with autoimmune diseases during this time period because their immune system is not functioning at 100%. So that's how it affects it. So your question about alopecia, it's important to know what the causes are. Sometimes decline in hormone levels can cause hair loss. Sometimes thyroid conditions can cause hair loss. Sometimes nutrient deficiencies can cause hair loss. So there's a whole bunch, and we need to look at that individually. A copy of Happy Healthy Hormones, which is, I think is a great book that encapsulates everything we talked about in more
Amazing.
detail.
So Happy Healthy Hormones, and then Estrogen Matters, and then the pausingtogether.com by Jill. And I'll share the recording after by email. But thank you so much for going over answering all of these questions about the complicated body. You were able to break down like these complex problems into very simple terms and explanations, which was amazing. So thank you so much, Doctor.
You're welcome. And if anyone wants to make a discovery call with me, they can go on dranat.com. I'm happy to talk to them further.
Yes, I shared your website, so yeah.
Oh, thanks. Yeah, but if anyone wants to talk about something specific, that's fine.
Perfect.
All right. Thank you so
Thank
much.
you so much.
Bye-bye.
Bye.